It's me again, April Gutierrez. I am a speech language pathologist, owner of Tiny Tongues of El Paso. This is Co-Treat with April, and I'm here with my guest, Miss Erika. Go ahead and introduce yourself.
My name is Erika Gonzalez. I've been practicing since 2013, so it's been a while.
Almost 15 years. Oh my gosh.
Yeah.
Okay. So Miss Erika was my clinical fellow supervisor. Can you explain what a clinical fellowship is?
So for every SLP that graduates, they need to have 1 year of clinical fellowship where they're just under the guidance of another SLP. The guidance has to be under an SLP that's been practicing for 2 years, and you were just such a joy for your
Oh
fellowship
my
year.
God, she's so lying.
You're good. I love whenever we have SLPs that will ask questions and crave knowledge, and you are one of the few fellows that I had that were always, what can I do here, or how can I do this better, instead of just coming into it like, I know everything, let me just get out of my way. But no, you were always asking, how can I do better, what else can I do, how do I do this? So that's always nice to have.
So I honestly credit this person, this beautiful person, for my entire career and who I am now and my entire private practice, because she took a chance on me. Tell me if I get the story wrong, because I tell the story all the time. You're like legend, like you're like part of the April lore. Is that I had just been hired, and we won't name clinic names, but I had just been hired at this clinic where Erika's working, and you had just been promoted, right, to clinic director?
Yeah.
Okay. So Erika, being the badass that she is, had a full caseload of feeding patients, right?
Mhm.
And not just feeding patients, I'm talking like medically involved feeding patients, and you needed to turn those patients over to someone, right?
Yes.
What was your thought process with that? Because I know I've known you for years now, and I know you are so invested in your patients. So what was that like when they told you, okay, girl, you're not going to be able to treat anymore, and then you have all of these like clinical fellows coming in? What were you thinking?
I was terrified. I knew that I was ready to teach other people to do it, but I've been with them for years, so they turn into your babies, and you're like, I'm gonna let my baby go with someone else, but knowing that they're gonna be in good hands, and knowing that you're gonna be able to be there to support them more, but still hard not being hands-on with them.
Yeah.
And I think it was more hard on the parents than the patients.
Oh my gosh.
Patients were fine with changing therapists. It's never the patients that have problems with it. It's the parents. They're like, but they know you, and they know your routine, but we got to realize it's time for changes sometimes. Sometimes we get into this routine, and it's time for them to grow with someone else and learn different strategies from other people, because everyone does it differently.
I love that you touched on that, friend, because I deal with that a lot now as a part. I'm like, I can't see everyone.
Mhm.
But to take it back to then, I remember you were like, do you feel like learning feeding? You had taken me on as a clinical fellow, and I was like, yeah. Mind you, I had received no feeding instruction at UTEP. For my cohort, when I graduated, we did not get pediatric feeding. We had one day where a feeding therapist came in and showed us all the different tools that one could possibly use in feeding therapy, but our feeding instruction was strictly for adults. We did get a swallow study course, which I'm grateful for, but I was just kind of like, sure, yeah, whatever. And then you just taught me everything you knew, and I fell in love. So the rest is history.
Yeah. I had the same experience at UTEP. I had two professors that were really good and taught me the little that I was able to get exposed to. But my main teacher was my clinical fellow supervisor. Her name was Rubina Rodriguez. She was amazing. She taught me anything from SOS to Beckman, and really she had all the severe patients at that clinic that I was at, and so she just threw me into the deep end. She's like, nope, you're taking them over, let's do this. And there was no hiding, you just got to go for it.
You do. I think that is so important. Feeding and swallowing dysphagia treatment can be super intimidating. And I think a lot of therapists, new therapists, are intimidated by it because, one, it's often medically complicated children, right? And you could hurt them if you do something wrong, or if you're not fully there and you don't know your stuff. Something could happen. It's very different from teaching, from treating language or articulation or even myo, I would say, right? So it's a lot to take on. What are the different trainings you had? Because you said something about Beckman and you said something about
So
SOS. So
my supervisor taught me in Beckman and the SOS, but I never got certified in SOS. So I'll say, whenever I'm wording it, I say, we'll take the steps. Never say SOS.
we're trained in it, and it's okay because I had this discussion with another SLP. So I'm sorry to interrupt you, but I think it's important to say, because a lot of SLPs don't know this, and a lot of SLPs reach out to me and ask me what trainings they should take. It's important to say that yes, you can be certified in SOS, in Beckman, certified in even in several mile courses, but there is no entity or agreed upon like certification that you must take to treat this. Feeding and swallowing, myofunctional therapy, voice, it's in our scope of practice. So if you have graduated with your master's degree as a speech language pathologist, passed your praxis, and have your license, you can treat all these things. Now, should you have the training? Yes, absolutely. But nothing is wrong if you did not pay thousands of dollars to get the certification. You also taught me Beckman, and you also taught me the SOS approach to feeding. Because for legal reasons, you cannot say you're certified in that because we didn't pay for the course, and so then the owners of those courses could sue us. But I say that I have been trained in it. Don't say I'm certified. I do say I'm trained, and then whatever wording. And even I remember in our documentation, you showed me how to like state it. So tell me, but I do want you to tell me a little bit about what is Beckman and what
So
is.
that's the first course that I ended up taking because I fell in love with it. And I actually got certified in that one, but it's a lot of the oral motor exercises, and it kind of goes with myo. So I'm like, they should just collaborate.
I use Beckman in my myo practice a lot.
And I liked the Beckman because she kind of touched base on those SOSs, like what are the steps. And she even has a checklist whenever you're doing evaluations. These are the steps that we need to get to. Where are they at? Just for insurance purposes, you can say, okay, they're at this step. We need to get them to this step by the next treatment period.
What are you targeting in Beckman?
In Beckman, we're talking about like the oral motor skills needed for that feeding.
And so, there's a lot of muscle work, right?
Yes, for sure. You realize how much all those muscles integrate together and how important each one is. So the cheeks, the lips, the tongue, everything all at once.
We take for granted, right? We take for granted swallowing, chewing, eating, but there's so much that goes into that your oral mechanism is doing, all the way down through like the pharynx to the esophagus. There's so much stuff that has to work like clockwork in order to have like a healthy swallow, right? A safe swallow. So I love that. So then I want you to tell me, what is the SOS approach to feeding? Because I think there's two very specific areas of feeding that are different. And there's one that is not my favorite. Like I love the physical, working with dysphagia. But tell me about the SOS approach to feeding and what that addresses.
So it works more on those kiddos that are more feeding aversion. So working through the steps. It's a lot of patience and a lot of reading your patient and going at their pace. So you'll start off with just, okay, we're just going to have a food that they don't like, and we're just going to have the presentations of it, and then go through the steps of, we're going to touch it, we're going to play with it together, which kind of goes in along with OT, and that's where we kind of cross paths with OT. But then we'll take it that step further in speech and actually do the eating of it.
So it's difficulty eating due to sensory aversions, right? Or picky eating, which there's picky eating and at one end of it. And then for me, I would say there's ARFID at the other end of it. Have you treated any patients with ARFID?
I usually don't get them with that diagnosis. They always end up with the diagnosis of failure to thrive, and I find most parents don't like that because it's a horrible term.
It is. I think I saw something that they're starting there to get rid of it.
Yeah, and it makes sense because one of the NICU patients that I had, she's like, every time I get the diagnosis with my son of failure to thrive, you're saying I'm being a failure as a mother. So I think we need to get rid of that one.
Right. So from that, you can see that feeding is like a whole nother umbrella of things. And it's part of our scope as speech therapists, which our scope entails artic, language, voice, cognition, feeding and swallowing. But then under feeding and swallowing, there's all this other stuff that goes with it too. And so, would you agree that there's not a lot of feeding therapists in El Paso?
No, and I don't think there'll ever be enough. There's so many patients, and we all need to just get on board and just take the dive, learn more, take those courses, learn from another SLP that knows. I think that's the best way to learn is learn from another SLP.
Right. And I love it. And I remember in grad school, it was such like a flex to be picked to do like the medical side of
Mm-hmm.
SLPing. But then once you get out, nobody wants to do it. Everyone wants to go into the schools, which they don't, SLPs don't treat feeding and swallowing in the schools,
No.
right?
Mm-mm.
Okay. And you do most of the time, probably 90% of the time, especially here because of the way things are at UTEP here, you have to get outside training and most therapists don't want to do it. I just had my SLPA. She helped me at Ready Reading Camp and she was like, oh, she's about to graduate as an SLP, Renata. And she was like, oh, feeding is not for me. I do not like that. You can do all the feeding patients you want. I love language. And you get those different types, which with Veta, who I just interviewed, she's like, I love it all. And I feel like you're very much the same.
Yeah.
You can do it all. I am not that way. I love the medical, I love the physical, and I think equally there's therapists who are like, I want to do literacy and language and make my cute little activities. And that's what, like, even Arctic, like, they don't even want to venture into like Arctic and speech sounds. It's like language therapists. So then you have like all these therapists graduating, and then, but nobody's becoming a feeding therapist, right?
Yeah.
And that's why, full transparency, right? We as feeding therapists, we tend to get better offers at jobs, right?
Yes, you do.
You do. You get better offers at jobs. Still probably not
And
enough.
clinic wise, you get reimbursed more for a feeding therapy session.
But still, therapists don't want to do it. Why do
Don't
you
want to do
think?
it.
And you've been in positions like we talked about of like hiring and
Mm-hmm.
interviewing. You're not right now, but you have had tons of those positions. Do you like try and convince therapists and they say no?
Oh, all the time. I will convert anyone and anyone. Like every student that I've had, they're like, nope, nope, no feeding. By the end of it, they're feeding therapists.
Yeah.
I think once you show them and you expose them to, it's just such big changes. I think for speech therapy, we don't see huge changes, but we see them in feeding. You can have a huge change, and it's so beyond rewarding. And the prize of it at the end is you're getting this family the ability to have their kid be part of their feeding ritual. So being part of breakfast time, being part of lunch and dinner, those are huge moments. And feeding aversion kiddos or feeding dysphagia kiddos, they're going to end up just not being part of that. And there goes the social aspects of their family, the strain on the family and the strain on the siblings because they're seeing siblings see, oh, why is so and so getting this food and I'm not? So there's going to be some strain.
Yeah.
So eliminating those big things are such a huge win.
Yeah, like you're a mom to two very
Yeah.
little ones. I'm a mom. Can you imagine like having to think about things like birthday parties? Like you can't ever just go to a birthday party and no, okay, my kid's gonna have cake and there's gonna probably be pizza. And no, you have to think like, oh, we're going to a birthday party. I have to make sure my kid eats before because they can't or they won't eat what's at the party. Or like even I've had parents worry about starting their kids at school because maybe like the kid only eats like three things and it's like, well, they're not going to partake in snack time or they're not, or what if there's nobody there that can help cue like my kiddo to eat, right? Or even with
Yeah.
like medically involved, who's like helping during feeding time, because all it takes is one thing to happen that could go wrong, right?
Yeah.
So I was going back to like not being enough feeding therapists. I know you say you'll take on anyone and train them to feed, as will I. But do you think it's something that can be taught in like 2 weeks
No.
after seeing like 3 or 4 patients?
No, no, not at all.
Mm.
You can turn someone onto it, but you have to have a lot more time. Yeah. A lot
Mm-hmm.
more time. So I think that's why we need to have more training in it in schools because that's not enough.
And right. And I was talking about this also with another speech therapist. You know that like every university is different. When I've made posts about like not getting feeding at UTEP, I've had therapists from other universities be like, we had like a whole semester on feeding. Like that's all we learned.
Yeah.
Like it really just depends on like the school you go to. I remember one time working for a company and we worked for this company together. And I think you and I were the only truly true feeding therapists on staff. But there was such a need. And I think I don't know if you were full time at that time. I think maybe you were like new momming it still.
Yeah.
And I mean, I'm only one person. I can only take like so many clients. And so this company was like, we need more feeding therapists. So what we're going to do is you're going to let these speech therapists follow you. And then, right, it was a whole, like they were already speech therapists. So I think the idea was, okay, they're just going to follow you for a couple of sessions and then now they're feeding therapists.
Yeah, that's how it was.
You had a great experience with that because you had a therapist who is a real go-getter and who learns quickly, um, and who's very bright. I don't think that therapist ended up going on to continue to be a feeding therapist, though. I think she ended up taking an administrative job. And then
Yes.
I
Yeah.
remember contacting you because the therapist I got, I just in not that she was a bad therapist, but I was like, after her following me in the first session, I would ask questions and I would be like, what do you think? What would you do? And it was almost a sense of like she wasn't taking it seriously and she was kind of like, I'll figure it out as I go. I'm already a speech pathologist, like whatever, like you're a speech pathologist, I'm a speech pathologist, like I'm just doing this because the company is making us do this, but I'll figure it out.
Yeah.
And I was really frustrated. And because we know it's so much more than that, these parents are putting these kids' lives in your hands, really and truly.
And then speaking of that, too, that she went off. So she only did those 2 weeks training with me, and it wasn't like 2 weeks straight, like a 40
No,
hour. It was
when you have
six
time.
patients. It was 6 patients total, and then I shadowed her for 2 of her patients, and it was only 4 sessions. So she was graduated to be a feeding therapist,
Graduated.
and then now that she's administrative, she's the one teaching the new ones in the company. And I'm like, that's not enough training if I've only had like this little tip of knowledge to give to you, and you're over here turning around teaching that. We need more. There
That's
needs to be more.
not even, is it not enough training, but you didn't even go out into the field and practice.
Yeah.
You like got the
Yeah.
training and then now you're training. And I think most parents don't realize that. And I think it happens a lot with big companies and big clinics, right?
Yes.
And I mentioned this in my previous episode that when you go to these bigger name clinics, and no shade, right? Because we need them, right? Families need them to access help. But it's not like you go in and then there's someone that's like, oh, sometimes there is. I bet where you work it is. But in other places where we worked, it's not like, oh, we're gonna give you to this therapist because they're really good at feeding, or we're gonna give you to this therapist because they're really good at Arctic, or maybe occasionally it happens, but that's not like the how it starts, right? If you have time, if maybe the parent requests, which a lot of times parents don't know that they can request, and maybe you'll get told no, and sometimes admin will probably get annoyed and be like, no, like this is who we have available. And I've had families come to me and be like, they wouldn't accommodate what I was asking. They said, I get what I get, which again, I understand. Oh, so many people need help, not enough therapists. But you as parents should know that if your child has a specific need, it's your right to be like, hey, does this therapist know what they're doing?
Yeah, for sure. And you're their advocate, so you need to speak up for them whenever they can. So you can choose which therapist you want, and not a lot of parents try for that. And by all means, be in the session if you want to. There
Mm-hmm.
should be no reason why any clinic, and there's a couple here in El Paso that do not let parents in. And to me, that's a big red flag, especially as a parent. My daughter and my son are not going to go in a room with someone without me there. Not because I don't trust you, but because I want to learn from you. I want to know what you're doing. I want to be able to use that at home. And if I'm not there watching you and I'm just going off of what you say in the 2-minute blurb that you give me after a session, it's not enough. You're going to be the ones at home with them, and you're going to be the biggest change for your child.
I know. And then, gosh, parents, it's important for you to know what your kid needs. And we were talking about this before filming, is that I am now getting older kids who are medically involved, meaning they have like a diagnosis that's like pretty serious, right? Or maybe they have like Down syndrome or some other kind of diagnosis that affects their feeding and swallowing and even their speech. And these kids are like 12, 11, 13. And when I ask families, well, what therapy have they received so far? And they haven't received OT, or they've never received PT, or they just started on their feeding journey like a year ago. And I'm like, what do you mean? Like, to me, with our cerebral palsy kids, our autism, our Down syndrome, our trach kids, our G-tube weaning kids, I think pediatricians should at the beginning be like, you need to go see a speech language pathologist, and not just a speech language pathologist, one that specializes in feeding. Do you
Yeah.
think that happens?
No, not often. The only time I see it happens is I'm getting a referral from the hospital from another SLP. She'll send a referral. I need an SLP to see him that has this training. That's the only time I've seen it specific, and that's not okay.
I know. And a lot of families, if the doctor doesn't say anything, if another professional doesn't say anything, then they're like, oh, well, that's it. Another thing that I feel like I see with these kinds of kids is like a lot of doctors or even other therapists. I had one mom say that the therapist was like, well, she's never going to talk. She's never going to eat normally. This is what it is. And then they come and see me, and then we make gains in like 2 weeks. And that is terrible. I feel like a lot of families get blown, or a lot of kids get blown off just specifically because of their diagnosis.
Mm-hmm. Yeah.
I mean, Down syndrome's a big one. Well, their tongue, that's just their anatomy. So, I mean, they're always going to have difficulty eating, swallowing, talking. Or cerebral palsy. Well, just be happy that they're eating.
Yeah.
You know
That's
what I
always
mean?
tough. Those are horrible doctors. I'm sorry.
Do you think, though, like a lot of the kids that we saw, do you think if things have been worked on starting early on by therapists who knew what they were doing, there would have been different gains?
It will be day and night. I think
Mm-hmm.
it's completely a disservice that we do for our patients. Even then, the therapist that I was back then, I'm completely different constantly. So, us as therapists, we need to change always too. So, we need to make sure that we do better for our patients, and that's by bettering ourselves. So, if we're not always going to more CEUs, trying to even go out, talk to OTs and PTs, figuring out what they're doing in their session so that we can implement it in ours, that helps forward, you know?
Mm-hmm. All right, girl, I'm about to get messy.
Oh, do
Okay.
it.
What do you feel about OTs treating feeding?
I think if you have a good OT, it helps. Like I had a really really good OT, especially right now. I have a little baby who's a preemie and complete feeding aversion. And because she goes before me in the home, she's able to work on the sensory play of it so that whenever I get there, I can work on the actual eating of it. So I didn't spend the for us at home it's 30 minutes only, so I didn't spend like good 20 minutes of playing with it before I got to feed him. So I got to spend the full 30 minutes feeding him and making bigger changes.
I
So if you have a good
love that.
OT, have them in your back pocket, talk to them constantly, call them constantly.
So tell me what you think the role is of OT in feeding.
I think it's more the sensory aspect of it. So desensitizing them to the smells, to the touches, to just having it on their hands, and then also so many OTs have helped me with positioning of them, PTs as well, but I find more OTs help me with. I've learned so much tricks of like putting the towel over here so that the way they have better head control, and then you'll have better process of that oral stage of feeding. So that's the main aspects that I see for OTs.
Do you think OTs should address swallowing?
I don't think
Your face, girl. You're like,
mechanics.
you know.
The mechanics, no, not the
So
mechanics. No, that's ours.
my friend Irma, she sent me this video from TikTok and she was like, girl. And I was like, what? And it's an occupational therapist who has her private practice. And girl, she is doing dysphagia treatment. She's doing feeding and swallowing. Like, I'm talking everything that we do. And I was like ready to be like a keyboard warrior. But then I was watching her videos and
She knows it.
she's doing the damn thing. She's doing more than what a lot of SLPs.
So that means we need to step up, SLPs.
They're
Come
gonna
on.
take our jobs.
OTs are doing it just by learning from. I wonder how she learned. You know, she didn't have to take a course in it, but she learned.
I'll send you her page.
I'll definitely, but yes, we're in charge of the mechanics of it, but we definitely work with OTs. OTs are our friends.
And I think as a private practice owner, thinking about if I'm not getting any SLP feeding therapists who want to come and work for me or work with me, because I don't like to say work for me, but I have an OT who's willing to learn and I can teach them. And I guess I would have to look up their specific scope, like
Yeah,
what is in their
definitely.
license. ADLs, like what else do OTs work on?
The fine motor skills and
Mhm.
the self regulation. So
They could, yeah. I don't know. I think now I could be open to it, but again, it's because no SLPs are like stepping up to be like,
yeah,
I want to learn this and I want to do it, and there's a need. Like there's a kind of like no, I'm not comparing OTs to. I'm not trying to piss off any profession. Okay, we're just having to. I think I'm like anything I say is gonna piss someone off, but like doctors have NPs where I'm not comparing myself to a doctor, okay, but like just as an analogy, have NPs or PAs, right? Because there's not enough doctors to service people, right? So I need to get help where I can. Girl, I know. And you feel, is your entire caseload feeding?
yeah, yeah.
What would happen if you left tomorrow?
I don't think anybody would take them on, but the place that I'm at, I love, and it's the only place where I've actually had a chance to grow and learn. And then I've been very blessed to have someone on call, but they're from different places from Amarillo, so I can constantly be like, oh my gosh, I had this patient, what can I do? And she'll call me right
Like
away.
a feeding therapist on
Yes,
call?
on
Stop
call.
it.
I love this agency.
Oh
Um,
my
and
gosh.
then you go in not knowing anything feeding, and you have 20 plus courses on your at your disposal to take at any time that you want. And that's where I've learned the most. And then on top of that, they're starting to do this the bridge gap. So from the NICU to home. So we're gonna start taking on those patients and get those certifications.
I love that.
So
I don't do NICU, I don't do babies.
those are fun.
I know you are. I remember one time you gave us a little like course with a little
Yes,
baby.
yeah.
My sweet spot is like two to adulthood when it comes to feeding. Not when it comes to anything else, but I need them to be at least two. So
And it's because their anatomy changes like so
mhm.
much. where they're at feeding wise changes so much. So it's feeding is a huge area.
So do you prefer doing picky eaters or do you prefer doing like dysphagia?
uh,
You have
I
to
like them
pick
both, but if I had
one.
to pick one, it would be dysphagia.
She's
But
another one that's like, I love everything. I do it
yeah,
all. I'm just like the best witch.
but no, I really, really do like dysphagia. I like seeing the changes mechanically. But my feeding aversion kiddos, they have my heart too.
Can I tell you, this woman, like, I had a client that I later came to find out has, we found out as a whole, me, parents, like, I had to see this kiddo for a while and do research to realize he has ARFID. But prior to knowing that, I was like, he's just a picky eater. And I was like, I can't get him to eat. It was like one of, I just felt so defeated after seeing this. And I like messaged Erica, and then she, something so simple, she sends me this Amazon link to this plate that's like a board game. And I was like, girl, I have done, this is like serious. And you're sending me a plate from Amazon. And I like ordered it anyway. And I was like, and I take it and I try it. And that first day, he got through the entire food item. I don't know if it was like a chicken nugget or a piece of bread or something from that thing. And I was like, what? And it's just like a testament to like changing one thing.
Yeah, and it's such a small thing.
I know, making it fun,
Yeah.
making it, having patience.
So that's what I'm saying. Like collaborating with other SLPs and OTs is so important because sometimes you get stuck and you get stuck in that, okay, I need to present this. How can I do it? And you run out of ideas, get someone else's idea. You don't need to reinvent it. It's already there. Just ask them.
I love it. I loved that so much. I've brought this up to a couple of guests that I've had. Okay, so I've worked in a lot of clinics, and you've worked in a lot of the same clinics. We follow each other.
Yes.
I follow her, and these clinics have PTs and OTs and then SLPs. And for me, like, that would be the dream. And you go into these clinics, and you're like, oh my gosh, and we always share clients with them, right?
Yeah.
Usually the client comes
Back
and
to
sees
back.
all three back to back. But I don't recall ever sharing notes or going in or having like team meetings like about patients. My recollection and my experience at all of these clinics that we, and I can think of like four that we've worked at the same, has been I see them, and then the PT sees them and OT sees them, and everyone writes their individual notes and nobody ever talks about what's going on. Is that how you feel?
That's how it is in a majority of clinics. I've only been to one clinic that they actually have team meetings and they talk about it.
And they talk about each individual patient?
Just specific problem ones, but never all of them. So that's
it should
always
be
hard.
all of them.
It
no?
should be. It should be. I think a lot of these clinics have this idea where when you get hired, they're like, oh yeah, we co-treat. And we even have an SLP who doesn't have a caseload, a PT that doesn't have a caseload, and an OT that doesn't have a caseload at your disposal. But they're really not. They're supervising or they're doing something else. So it's really hard to have any collaboration there. So,
or they're like, or OTs will be like, I treat feeding.
Yeah, yeah, that too.
And which, dude, honestly, I'm like, I would love to talk to an OT about feeding.
Yeah.
I would love for us to be able to treat together. I would love to teach you and you teach me, but it's like nobody wants to work together. For example, my one client I have specifically, I already know what I would ask a PT. I would ask a PT to help with like trunk support, a lot of her gross motor stuff, and like OTs I think do like hand to mouth, just all the things that I'm treating like the oral stuff. But every time I see this client, I'm like, oh, how much more progress we would make if she was able to hold her utensil for a long period of time. And actually, I've started working on her like crossing midline, and because I don't have someone, and because for safety purposes she does need to be able to like not favor one side, or be able to hold her utensil to where she's not shoving it all the way in her mouth and choking herself, or be able to know, oh, the spoon is too far in. I need to be able to pull it out. But ideally, you would have an OT also working on that or a PT also working on
Yeah,
that.
it's just a weird process because you have a time period where someone's working on this part, a time period where someone's working on this part, and a time period where someone's working on this part. But if you have a time period where all of this is working together, the progress should be quicker, right? But we don't have that.
In an ideal world,
Mm-hmm.
right, where insurance doesn't dictate the time or the amount of
Yeah.
people that can work at one time, right? Because you can't.
It used to be like that whenever I started. So whenever I started in 2013, there was a time period where you can have a 15-minute co-treat session. So there was an overlap, but our sessions were an hour. So insurance, we would bill the one code for treatment for 30 minutes and then a bill of another code for another 15 minutes and then that co-treatment. We would overlap 15 minutes. That's where I saw the the OT. She would come in and she would sit behind him and help support him and help bring it to the mouth, and then I would help with the mechanics of it. So it was nice flow, but then they decided that speech only needs 30 minutes, so we lost all that.
I want to talk about how early identification of like patients that would need feeding. Okay. So I want to talk about why is it so important? Okay, let's just talk about one population, for example, that I'm seeing. And it also like comes back to my Mayo with a child with Down syndrome. There's a lot of structural things that just come with a diagnosis. And I think because of that, a lot of not just speech therapists, but also doctors, dentists are afraid to touch it. A lot of times, individuals with Down syndrome will have heart issues, right? I had, Dr. Yates told me that a lot of times you have to be careful with remove, even though individuals with Down syndrome have lingual restrictions, you want to be careful with removing it because sometimes it's the only thing stabilizing the tongue from falling back
Yeah.
into their throat. And I
Yeah.
never thought about that. I was at this conference and I was like, why aren't you guys like yelling at all the doctors and dentists
Their
removing?
anatomy is different. Their
Mm-hmm.
anatomy is way different.
But on the other end of it, we should always at least try something.
Yeah, just because their anatomy is different doesn't mean you can't work on it. You can still fine tune it.
Say that again because your hands were in front of your face and that was so, I love what you just said. That even though their anatomy is different, you can still what?
You can still make change.
You can still
fine tune it.
Fine tune it. I love that.
So I have a 7-year-old I've been seeing. It's been not even the 6 months, but he had never had oral motor therapy with Down syndrome, and I find that mind blowing.
Why? Why do you find it mind blowing?
Because their tongue is so different, and because they have such a bigger tongue, they have a harder control of that bolus while they're feeding, and they have a harder control of their speech. So if nobody's working on that tongue ever, it's just going to stay like that.
So what would you say to a doctor that's like, it's just how they are?
It's not, because I've seen the change. I've seen it happen in person where this kiddo, nonverbal and only tongue thrusting while eating, now can hold the bolus in his mouth. We're still working on the lips to close, but he's getting there, and now he's starting to say words. So that's an old change. If this would have happened way sooner, who knows?
I've had, and I know there's medical things also, and there's different levels, but I've gone to homes where like the kiddo is just nonstop, like the tongue literally sits outside the mouth, and this kid is like 11, 12 already. And you think like a kiddo like that, if it had been addressed when they were 3, 4, 5, something could be done.
Oh yeah, and then even then, it's not too late. You can teach them compensation strategies.
But
it just
harder.
Sucks that it's later.
I think it's really important
less
to say.
Change. The bigger change you'll find is if you start sooner. The sooner you start, the bigger the change. The later you start, the smaller the change, but still good change.
And to that point, again, I get, just because of the nature of my practice and how I started it and what it's become, I get a lot of families that are unhappy with their therapy journey. But because of that, they come to me when this kiddo is already older, right? Also, they come to me not having been told the consequences that come with not teaching a safe swallow or an appropriate swallow or not working with the musculature early on. So then I kind of have to sell it. Like they come to me, but I don't think they know why they're coming to me. I think they
Yeah.
just know they don't like what they've been receiving, so they want something different. And then, but then when I'm like, hey, the implications are that as we get older, the musculature starts to atrophy, right?
Mm-hmm.
And because of this diagnosis, they already have weak muscles. So we need to work on those and teach them how to swallow safely, because the reality is you're not always going to be here,
Yeah.
and you're going to have to count that wherever they are when they're of a certain age, that they can swallow safely, that they can feed themselves safely, because nobody's going to love and take care of your child the way that you do. And that is, Erica, when I tell you, it is so hard for me to pull that out and tell a family, because you know that they already know about that
Oh
reality and they
yeah.
think about it all the time. But I like to be the person to like say that to them.
Verbalize it.
But we have to, because
Yeah.
as feeding therapists, that is our whole purpose, is teaching safe swallowing so that they don't aspirate.
Yeah. Mm-hmm. For sure. It's hard.
So
It's really
tell me,
hard.
Erica, tell me what tends to happen with medically involved people with Down syndrome, people with cerebral palsy, people with weak musculature, when they're older, or just in general, what are the dangers if we don't address feeding and swallowing?
So it can be a quick decline. They're going to end up being G tube fed
Why?
because they can't safely swallow. They're going to aspirate or penetrate something,
Why can't they safely
and
swallow?
because of the mechanics
Because
of
they
it.
can't maneuver.
Yeah. So if you let the mechanics, it's like a muscle, any muscle. You let it go and you just let it go, it's going to get weaker and weaker until you can't use it anymore. And whenever it's something, even though it's a small muscle, it's so important, like the tongue or any of those oral motor muscles, it will down spiral the feeding process and they can lead to them being hospitalized.
What would you say to a parent of a child who cannot chew food but is not G tubed, is breaking down food using only the tongue, has done it their whole life? What is the outlook for that child if they don't receive therapy?
It'll it might seem easy and quick that you're doing it that way, but it's going to be harder and harder as it goes. It's never going to be like that long term. Like if they can thrive with just like mashing it against the roof of their mouth,
Yeah.
oh, that would be easy. But it's going to decline.
And then you would need to choose, right? You need to choose. Okay, then we're gonna just do puree.
Mm-hmm.
You
Yeah.
need to decide, okay, my child's never is not going to chew. And that's again another thing that happens when physicians, pediatricians, therapists in town don't present these realities to parents, either because they don't want to be the bad guy, or they don't want to deal with it, or they don't know what to do. Now,
Yeah.
even doctors don't always know what to do. If you Then the parents are just left figuring it out on their own. And then, for example, if a kid, yes, at home, you know what to do and you know exactly how to prepare the food and you know exactly what food the kiddo can eat and how to present it. But what about when they're at school? You really
Yeah.
are going to trust every single adult, every single person, and maybe the adults around them are trustworthy, but all it takes is for me to like look away for 1 second,
Yeah.
and something to go down the wrong pipe, or them to put something in their mouth that they can't break down.
I think it would be hard to live like that because you'd be in constant fear and always have to be on the ready.
Mm-hmm.
You have to be on the ready just to like protect them because you're not giving them the tools to protect themselves.
Mm-hmm. And also on the other side of that, if they can, if they do have this buildable skill, then we should be working on it.
Yeah.
We should never, as a therapist, be like, it's too hard, I'm not going to work on it, they're doing just fine, which I've heard a lot. Like, get a chew tube out and see what they can do.
Yes.
Which,
And another thing is times have changed. Back then, if you got a patient and they're like NPO, I know most clinics are like, nope, Don't do it, don't touch it. Now the times are changing. If they're NPO, that doesn't mean you don't give them tastes. You want them to start working those mechanisms because you and I do it constantly. We're swallowing our spit. So we're constantly working on it. So our buildup of that muscle back here is good. But these kiddos that don't have any taste or any desire to swallow their saliva, they're that muscle's not being used. So then we send them for an MBSS to get a test done to see how they're swallowing. Of course, we're setting them up for failure. You don't. It's like the Super Bowl for them, and we're sending them in without any practices and just, okay, let's see how you do it. No, you need to practice beforehand.
Oh, they're not
before
using those muscles. Well, yeah.
They're gonna do bad. And then it's MBSSs are scary.
I think we need to tell them what an MBSS is because
yes.
we're nerding out on our
So the
feeding.
modified barium swallow study, it's done in a hospital, and they're checking the mechanics to make sure that nothing's aspirating, nothing's penetrating. But you take it into account, they're being fed by someone they don't know, another SLP they've never met, in a giant machine, in a giant room that they've never been into.
Tell them what happens. So how does it work?
So then the SLP will present them with different trials, and then they'll have picture and they'll swallow, and then they'll see what's happening down here to make sure they're not penetrating or aspirating anything.
It's really cool. So like what they do is they give you dye, like the food has the dye in it. Yes. Right? The presentation has a dye that
it doesn't taste good.
No,
no,
I don't think yeah. So and then boom, like your kid's X-ray is on a screen, and in real time, you can see what is happening from the moment the presentation enters the lips. So even we're looking like, are they able to like get food off the lips? Is it just staying there? Do you have residue to what they're doing when they're chewing? When they're swallowing liquid, is it just going all the way down? Or are they able to control it? You can see if it's like, what is the little crevice? Girl, Dr. Lada's gonna get me.
Me too.
There's spaces between your mouth and your esophagus where food and liquid can go, and food can get lodged, and then hours later, right?
Yeah.
Something dislodges the food, and then you have the kiddo chokes, right? Same with liquid. If it's not a complete swallow, or if it's going down the wrong pipe, it's like buildup that causes the aspiration.
And then
right?
the eventual pneumonia.
There's so much. And do you see why you cannot just like walk in as an SLP and be like, I'm a feeding therapist?
Yeah. And I've done it for years, and I don't know it all. I'm constantly asking questions. I'm the perform sinuses.
Yes. See, girl, I knew she would know it.
It's all in there.
It'll come out. And even if I don't know the word, I'll be like, there's a space where the food will get stuck. And I have the picture in, because what is that thing we took in school? It's like by NYU. You had to take a course. I don't know if you guys had to take it.
I don't think
That's the one thing I'll thank Dr. Lada for. We had to and we had to watch like 20 swallow studies. And then had to label like what was happening at which part of the swallow.
See, I'm telling you, every year people get better.
Yeah.
Universities get better, because I didn't have that when I was in school.
There you go. You just had to raw dog it.
Yeah.
We don't want to let that go. And more providers, more professionals need to put more importance on, yes, it's important. I know a lot of times, a lot of doctors are just trying to like keep a kiddo alive.
Yeah.
Healthy. They're more worried about
they're looking at the weight and making sure everything's good there. So they'll try and get the volume in there by any means necessary. And sometimes that's not what's good for the kid.
Yes, that's great, because I will have kids. I already know when I see a kid and, oh my gosh, like they have dysphagia or they're not eating properly, but they're at weight. Mm-hmm. But why are they at weight? Well, because they're like living off of protein shakes, or because they're like mashing food, or because they're only eating one food. If we're talking about a picky eater, they're like making weight because they're living off of like Cheetos and I don't know,
all those crunchy foods.
Sticks. Yeah. So just because your kiddo's at weight, just because they have adapted, does not mean that is the right path that's going to keep them healthy and thriving, giving them their optimal quality of life,
Yeah.
right? So, the last thing, I want to talk about what a full feeding eval looks like. Because, again, because of time constraints, because of insurance, because of just like lack of knowledge, I think that there's a lot of shortcuts taken. So, I want you to walk me through what your evaluation process is for a feeding patient.
So, one thing I discovered recently with the agency that I'm working at, Home Health, is a website called Feeding Flux. So, they have so many tests available, and they're all free. And they're not standardized, of course, because nothing in feeding is standardized. No matter how many times the insurance asks for it, it's not going to happen. But they have scores to them so that you can see the progress that happens. But I'll use those a lot, so I'll always have them on the ready. So there's one called the impact of the feeding against the family or parent. So I'll use those for my feeding aversion kiddos because you want to know the impact it's having on their family. For a start, always is the history, which sometimes it can take a long time. So what I'll do is I'll call beforehand and I'll ask, what are they doing? What are they not doing? What do you want them to be doing? Because if the parent is satisfied with them being there, we need to change their minds when we get there. Because even though they're satisfied, there's more. So we get the history before going because we don't want to waste our time on that. And then we get there and we'll be prepared, but sometimes things get thrown at us. So I'll ask them to have a food ready that they give them, and I just want to see what they do before I intervene. So once I see them go through the process, I'll make suggestions, we'll make our changes, and then see if that helps or it doesn't help. So that way I can see, are they a good candidate for feeding therapy? And then we'll do the full oral mech just to make sure nothing else is going on there.
What's an oral mech?
Checking all of their anatomy, making sure everything's good, the function of the anatomy, and then seeing how they're doing at rest too. That's a big one. Is if whenever you and I are talking, what are they doing at rest? Are they having their mouth open? Are they having their tongue out? Are they able to control their breathing? So a lot of aspects that we're looking at in a full feeding um, evaluation. And then on top of that, you want to also look at their trunk support. Are they a bedridden kiddo? Are they in the wheelchair? Because those are big effects to their ability to swallow. In an optimal world, we'd be able to sit straight and hold our head straight, and that would promote a good swallow. But if our kiddo has like torticollis and is on one side, or cerebral palsy and they can't have good control, those are aspects that we're going to be looking at. And then there's a whole different difference with an assessment of a baby feeding, which I'm still learning on. I'm excited to learn on, but from the parts that I did learn, it's a lot more interactive because you're looking at not only bottle feeding, but you're looking at breastfeeding, and that's a whole nother beast too. So, and then as a new mom, my daughter was born with a really severe tongue tie.
I remember.
And feeding her was painful. And I got to see firsthand how we did the lip tie release. We left her tongue tie.
You left the tongue tie?
We left the tongue tie because it wasn't as bad. And she can still lift her tongue. And with the release of the lip tie, she was able to suck. And she's my first breastfed baby. With my son, I tried, but he had a bad tongue tie.
They're genetic, friend.
Yeah, it's from their dad. Their dad has a tongue tie too. So whenever we got his tongue tie release, I had issues with the veins on my legs and had to go to the ER. So they gave me medication that stopped the milk, and so I wasn't able to breastfeed him. But yeah,
this is great lead into like my next question. Okay, so I just want to ask you from your experience, what are the effects that anatomy has on feeding and swallowing? How important is anatomy, both like structurally and function wise? Like, what difference does it make?
it's the main thing. I think it's the main thing of why I like feeding, because without one structure working, it kind of falls all apart. So we need to make sure all structures are working, and then don't be afraid to ask the doctor, why does this look this way whenever you see something abnormal? Because whenever I went to, like I said, with my daughter getting her lip tied, I was in the dentist's office and there was two other babies there, and they're like, "Oh yeah, she has a tongue tie, but we're still trying to see if we still need it done." And I look over, and I'm like, "Yeah, it would really
Mm,
benefit." So then I would tell her like what questions to ask and to really show them like, "Look, when I'm breastfeeding, this is what's happening, and breastfeeding shouldn't hurt." So
never. It should
yeah,
not hurt. Yeah,
learn
exactly.
that the hard way.
I don't work with babies. I leave that to others, but I do know that. Nothing about anything that we do naturally, feeding, breastfeeding, nothing should hurt. And then additionally, I wanted to ask you, just for our send off, what are some like red flags to look for like in feeding? And I guess it's different. Feeding is different than speech, right? You're not very often going to see like a typically developing kiddo who has like signs and symptoms of dysphagia. You either have it or you don't. A lot of times we see it in our kids with Down syndrome, cerebral palsy, anything that's like structural, maybe like Williams. I don't know. Can you think of other trach kids, kids with YouTube? Can you think of any other um, diagnoses? There's so many. There's so
Yeah,
many that affect
torticollis.
feeding.
Torticollis is a new one I've been seeing a lot more.
I saw a kiddo with that diagnosis. I was screening him for Mayo, and I had to go like learn more about it. I didn't realize how much that affects like
Yeah, it really
everything.
does.
And mom's a dentist. Let's say I have a child with Down syndrome, and weight is fine, eats everything, loves to eat, but there, what would be some signs and symptoms to look for, even though they're eating, to show that the feeding mechanism isn't working well? Do you get what I'm saying?
Yeah, so we want to check, how are they eating? Is anything coming out? Are they using their tongue to eat? So like mashing with their tongue. Are they having any signs of coughing afterwards,
Big one.
or wet vocal quality after they swallow, or even later on? There's also the GERD. So there's a lot of aspects to look on, but the biggest red flag is looking at their ability to have their food, or we call the bolus, and keeping it in their mouth without anything coming out after they swallow. Look inside their mouth. Is there anything left over? And can they feel that anything is left over in there?
And the coughing, right? and
Yeah.
and the wet vocal quality is a good one. So a lot, something I will always tell parents is like, okay, after they've had a meal or they've drank something, have them go ah, and if you hear that wet, that with wet, we're saying like gurgly, right?
Yeah.
And what's happening is that there's still something sitting over the vocal cords. They haven't completed the swallow, so there's residue, there's liquid, and so that's what's causing that gurgly sound, and that shouldn't occur there. That means
No.
they have an incomplete swallow. That means, and that's really dangerous because then later on that can cause aspiration or aspiration pneumonia. Equally with like leftover residue that they cannot feel in their mouth. That can also, if they have that in their mouth and they don't feel it and they can't swallow it, maybe when they're playing or when they're sleeping or whatever, that food again can get dislodged and they can choke on it, right?
Yep.
I mean, that's like an extreme, but these are all things, it just takes one time. Again, it just takes one time. Well, thank you for being here, friend. I could talk to you forever.
Same.
My mentor. Erika is another feeding therapist in El Paso. If you guys want her information, I'm happy to give it because, again, we can never have too many feeding therapists.
Yes.
And everything I learned from her. So,
And if you're an SLP looking to learn more, reach out.
yes.
Reach out to someone you know. If you're uncomfortable with going to someone you never met, there's feeding therapists here and there. Just reach out to them.
Yes, reach out to me and I'll give you her information because she can point you to all the courses, all the tools. To this day, she still sends me stuff like all the time that she knows I can use in therapy. So
Share knowledge. If you're an SLP feeding, share knowledge.
don't be a
Yeah,
gatekeeper.
never. That's why constant people are always getting my messages, because if I learn something, you're gonna learn it too.
I love it. Yes, clock that. All righty. Thank you for being here, Erika.